Good afternoon. My name is Sylvie, and I will be your conference operator today. At this time, I would like to welcome everyone to the National Learning and Action Network follow-up conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Lindsay Kirsch, you may begin your conference.
Thank you so much, Sylvie, and good afternoon, everyone. Thank you for joining us for the National Learning and Action Network follow-up event. This is part of our quarterly Sharing Knowledge, Improving Healthcare series. We are very happy to have you with us today as we follow up with the speakers from the November 1st National Learning and Action Network, or LAN event, Effective Co-Management of Mental and Physical Chronic Conditions. My name is Lindsay Kirsch, and I'm a Program Manager for Intelligence. I work with the Quality Innovation Network National Coordinating Center, or the QUIN-NCC. A few reminders and housekeeping items before we get started today. First of all, thank you for joining us in the WebEx Event Center. To join the event online, you will need to access your registration confirmation email and registration ID to log into WebEx. My colleague, Karen Tenkate from the Quality Innovation Network National Coordinating Center will be monitoring our WebEx chat board, so please be sure to participate as we go along and feel free to ask your questions. Slides, resources, and the recording from today's session, as well as the November 1st session, will be posted to the QIOprogram.org website under the News and Events tab, and some of the resources are already posted there. So we'll start by reviewing today's agenda. I will introduce you to each of our 3 speakers today, Eric Christen with the Center of Excellence for Integrated Care, and Dr. Paul Chinaski with Same Page Health. They will recap their presentations from the November National LAN event. And we'll hear from Michelle Hoover and Archie Hamilton with the Adam Alliance Quality Innovation Network. They'll share about how one of their communities has integrated behavioral and digital healthcare practices. We will have 2 separate facilitated discussions, one after Eric and Paul's presentations, and the other following Michelle and Archie's. And finally, I'll wrap up with a reminder to complete our post-event assessment and a plug for some upcoming calls. So I'd like to take a moment to remind our participants about the purpose of this important series of learning and sharing events. I won't read all of the content on this slide, but just to mention a few high points. Our audience is very broad and includes a variety of healthcare provider types, partners, and patients. Our purpose here today is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. We would like to ask that you all think of actionable ways to implement the ideas and concepts presented today and make a commitment to share the information with your own teams. And finally, we are always open to new ideas and suggestions for topics to bring to this audience. So please feel free to send your ideas through the chat and or through the post-event assessment. To address the direct purpose of today's event, we are aligning with Centers for Medicare and Medicaid quality strategy goals to promote effective prevention and treatment of chronic disease. So again, we're hoping to make this as interactive as possible, which can be challenging given a large audience. Therefore, we ask you to commit as individuals to be attentive, active, and actionable, thinking about all of the ways that content is relevant to your work and priorities. And we welcome your active participation by clicking the green check in the WebEx application. So you can click the conversation bubble, choose yes in the drop-down menu to tell us that you are going to be attentive, an active participant, and actionable. So instead of doing an actual poll, we are just asking you to chat in your answers for some questions we have here. So we're just wondering if those attendees on the line, participants, if you attended the National LAN event on November 1st. So please just chat in there, yes or no. Give you a few seconds to do that. Let me see some answers coming in. Quite a few no's and yeses. So the next question we're going to ask is for you to chat in which entity or type of organization you represent. CMS, a home health agency, hospital, a nursing home or skilled nursing facility, a patient, family, or caregiver representative, pharmacy or pharmacist, provider or practice, QUIN-QIO, or something else. This gives us an idea of who is on the call, who our audience is. And I think last time we did have some trouble with the poll, but we know we had quite a few hospital representatives, as well as provider practices, but the majority were from Quince Royal. We did have about 6% were from skilled nursing facilities. And I think in terms of people that were others in the LAN event on the 1st of November, we had health plans and payers, managed care organizations, consultants, health systems, AAAs, and representatives from the beneficiary and the BFCC QIO. Okay, thank you so much for those that have chatted in their answers. So as I mentioned during the November event, the topics of this event series align with the CMS quality strategy. And the CMS quality strategy guides the healthcare transformation activities from the federal, state, and local levels, including those that you all are working on in your communities. The CMS quality strategy prioritizes 6 goals for success. The topics on today's call, as well as the November 1st National LAN call, aligns with the CMS quality strategy to promote effective prevention and treatment of chronic disease with an intended strategic outcome of reduced and prevented leading causes of mortality. In November, you heard from 2 very passionate speakers, Eric Christian and Dr. Paul Chmerowski. Their missions focus on improving patient outcomes by effectively addressing individuals with multiple behavioral health and medical conditions while integrating physical and behavioral health care services. We're very grateful to have Eric and Paul back with us today, and we're also excited to welcome Michelle Hoover and Archie Hamilton as speakers. They participated in the November 1st event and will share about their journey to integrate behavioral and physical health care practices with a particular community. So it is now my pleasure to introduce Eric Christian, Technical Assistance Consultant of the Center of Excellence for Integrated Care. Eric will provide an overview of continuum of collaboration and outline evidence-based behavioral health integration models. So Eric, the floor is yours.
Great, thank you. Appreciate being here. As was mentioned, the title is really talking about effective management of mental health and physical conditions and having some integration between those. It reminds us that whole healthcare and approaching that patient from these 2 different angles really requires working together, and that the cause of this is all the energy behind integration really is because of the majority of folks who have comorbid mental health and medical problems often do not receive care consistent with established practice guidelines, such as if an antidepressant is prescribed in primary care, that patient may not be seen within the intended time frame for follow-up that is recommended. And often when we have integration, we can meet those behavioral health guidelines a little easier, and they're certainly a lot more aware of them. We're also reminded by George Engel that in caring for the whole person, it requires a really comprehensive approach, a biopsychosocial model of approach and assessment, and that at any one time a person is biological, has psychological concerns, may have cognitive issues, there are social aspects, they have interpersonal relationships, they're on some developmental continuum, and there are other culture and contextual factors involved, and we need to involve all of these in the way that we treat the whole person. As we talk about integration, it's often placed on a continuum, and the way that we can kind of think of this from left to right is just thinking about how close these parties and clinicians in this case might be working together. On the left, you have coordinated care, where providers might be working in their own buildings and facilities, as shown by these test tubes, and hopefully there's some communication across town where messages are being sent up and out of the other into another test tube, and you may be aware of how difficult that can be. We still need to have this because we can't all be integrated for all types of specialty care and conditions, but there's often a lot of work to be done in just getting that information in a timely factor so that it is as close to the point of care as possible so we can make decisions with the patient and keeping those other providers in mind. As we move towards the middle of this slide, you'll see co-located care. And this is where we essentially have providers working together under the same roof. They may be across the hall, they may be 2 separate businesses for all intents and purposes, or they may have some things that they do together or share some efficiencies. We've seen where sometimes they're sharing staff, or they're a business within a business and the therapist is down the hall, but they may schedule their own appointments and not interact much throughout the day, and this would be what we would call co-located care. But often those providers start talking to one another, and decide to move down the continuum to integrated care, which is where we're all working under the same business, and we're all working for that one patient on that one care plan. And typically, in a primary care facility, this would mean that the PCP or the primary care physician or provider is the lead of that team, and the behaviorist is working with them as the primary care provider as their one consumer on behalf of the patient and the rest of the team. There are three models when we talk about integration. There's the primary care behavioral health model, which is where we have a generalist on the floor, in and out of exam rooms, much like our nursing staff are, with specific roles and protocols that they're fulfilling, and they're available right then and there to meet the patient, to begin an intervention, and it really mirrors that primary care style of brief intervention. We have ESPERT in the middle here, which is a vertical protocol designated by the arrow, which is really focused on screening and brief intervention and referral for treatment for alcohol and substance use. And this is a way in which we can quickly assess motivation for patients to engage in care and get that care, whether it be on-site or with a referral. And then there's the collaborative care model, which is this registry-driven model where patients meet a particular threshold for care. We have medication and visit algorithms that they participate in to designate when we do what we do. It's disease-focused and it's vertically integrated, and Carol is going to be talking a lot more about that in the next few slides. Bidirectional integration. This is where we have primary care providers integrated into specialty mental health settings. And the focus here is really on targeted medical conditions for the population to get patients established who may not be seeing primary care, may have conditions that they're aware of or unaware of that need attention. And it's also on a continuum. It could be coordinated, it could be co-located, or it could be very much integrated with one medical record. But it's important to note that this does not replace the need for more intensive specialty care, or even the efficiencies of a full primary care clinic where we have, a larger lab, we have X-ray machines, and so it's a nice way to enter into care for patients who may not be participating in traditional primary care services. I'll pass the ball back to Nikki so that we can move on to Paul's presentation.
Thank you so much, Eric. We appreciate you being here with us again. So it's now my pleasure to reintroduce our next speaker for his presentation recap from last month. Dr. Paul Chinaski is the founder and chief medical officer of Same Page Health. He's also a clinical associate professor of the Department of Psychiatry and Behavioral Sciences at the University of Washington. Paul, the floor is yours.
Great. Thank you, Lindsay. What I'd like to recap today is the collaborative care model. And so essentially this is about integrating care, collaborative teams, the way that Eric presented about along the continuum. This is a way for teams to work together around common goals. And so collaborative care, just to recap, is a team with a shared mission using improved clinical systems to deliver care to a patient population. And this is supported by operational and financial systems with continuously evaluated process improvement and effectiveness measurement. So where the old model might be PCP and patient, we've added care management, but this goes one step further where we have what's called systematic case review. And this is really the differentiator of this model, where we remove silos and we have shared goals as a team. We come up with action steps based on weekly data that we have, and that's conveyed to the PCP of the patient, which is on the left of this diagram. And so it truly is removing the silos as much as we can, and we can speak more to that in the discussion. So our evidence shows that, indeed we're focusing on much more than just depression, where a lot of collaborative care has lived in the past, and we are focusing on the whole patient, particularly as an example, focusing on a segment of the population that has diabetes, depression, and hypertension, and we're focusing on A1C, blood pressure, cholesterol, and depression, of course, many other things. Just as an example, why it works is that, with people that have multiple chronic conditions, they often are on many, many different medications. And while we're working on behavioral strategies to quitting smoking and so on, the reality is that we have to focus on improving titrations of medications and make this much more effective. And as you can see in the pink bars here, this is a control group in a randomized control trial. And it just shows that people that have one or more adjustments amongst these complex patients are very few in usual care. That's what we call clinical inertia, and that's what we're addressing here. So the cycle of collaborative care is to identify goals of the team, not just of the patients, to use evidence-based behavioral strategies. And then the three things at the bottom there: monitor progress, treat the target, and having a weekly check-in, a systematic case review with a psychiatrist and an internist, and sometimes we have pharmacists, diabetes educators. And then within that week, conveying that information to the PCP. So again, it isn't a siloed out program. A review of systematic case review, again, the key thing here is that it's data in and data out. It's really dependent on data to make sure that we're addressing targets in a way that makes sense and that we are moving those immediately to action steps. And then finally, the beauty of this program is that we are focusing on depression, but in the context of multiple chronic conditions. I won't read all of these things, but let's just say that there are many aspects of treating depression that are taken care of in this way, leveraging the use of a care manager who is very comfortable with those skills and who follows up with the patient around the heavy lifting on things like self-management, education about medication, treatment adherence, and other things like that, as well as behavioral strategies, decisional balance, behavioral activation, problem-solving treatment, all evidence-based. So in summary, this model addresses depression and anxiety in the setting of comorbid medical conditions, addressing those 5 or 10% of people that account for 50 to 60% of the cost. It addresses the how to the analytics what. We find the gaps, but how do we address them? And then addresses health behavior, not just behavioral health. It's truly a population health approach. And generally, healthcare providers, PCPs love it because it's kind of a built-in curbside consultation from a psychiatrist and a review of cases on a weekly basis. So I'm going to stop there because we have time for questions, and I'm going to pass the ball back, I was told, to Nikki, and then we'll go from there. Where's Nikki here?
Thanks, Paul. So we really appreciate you and Eric joining us again today. At this time, I'd like to open up the call for questions and comments for Eric and Paul. So I'm going to invite Karen, our chat facilitator, to share any conversation that's been happening in the chat, any questions you posed.
Hello. Yes, we have no comments at this time or questions in the chat.
Great. So did you want to open up the phone line and tell participants how they can dial in for a question to our presenters?
Absolutely. So at this time, I would like to remind everyone, in order to ask a question, that's press star and the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Again, if you would like to ask a question over the phone, that's star, then the number 1 on your telephone keypad.
And while we're waiting, this is Karen. I have a question for Eric. What do you see when you're out there consulting? What do you see as some of the challenges with each of the models?
Sure, it definitely is model dependent. A challenge for the TCBH model, that's the consultant on the floor, moving in and out, is sometimes, and it's surprising, is sometimes getting enough work. Primary care providers in this case being used to sort of stopping themselves and, bringing in that behavior as for that intervention and moving on. It's just getting that workflow going, and so we usually set a precedent, we're looking for one handoff per provider per day to start, because that'll always get us in the ballpark of what we're expecting to see. For the expert model, that's what we're doing is training, brief intervention, and referral for treatment. Some of the challenges are similar in stopping for that one item to happen, and so I don't see that model happening as often on its own, but rather a part of the consultant model, because if you only have expert and you're only stopping to do some enhanced brief action planning on substance use and alcohol, that might be too narrow of a condition array to stop and bring someone else in on versus if it's just all behavioral health, which would include substance use, that's a little bit easier to sort of predict. So the collaborative care model, sometimes paying for the psychiatric consultant is the biggest challenge because that is not easily reimbursable. There are some changes coming up in 2017 through CMS for Medicare that are really going to blow this wide open and allow folks to apply the model, and that psychiatrist consult will be less burdensome financially.
Great. And on the alternative, do you have any advice for, say you have a large primary care practice, maybe with, hundreds of providers, or any certain condition with primary care practices? How would you go about helping a physician group decide what model would be best for them?
Sure. It really can be contingent upon, what they envision their workflow looking like, because that consultant model really is adding a new person to the team. And I'd encourage that as sort of the baseline model because it's for all comers. It serves all patients, whereas the other two models really are sort of population-based for a smaller sliver, which is very helpful. And they can run concurrently. So inevitably, if you start with the consultant model, you will start to talk about these patients that just keep coming to mind or hitting a particular threshold that maybe aren't doing well, and what could we be doing more for them? And all of a sudden, we're talking about a registry, and shouldn't we then just make it a collaborative care model where we've got metrics and measures and return on investment that basically is plug and play. If you do this, you'll get that. It really is sort of thinking about how providers on the floor will be interacting and what level of initial disruption they are willing to deal with. After a while, though, they'll not let it go once they get used to it because it's going to allow them to move along a little faster, see more patients per day, increase their satisfaction and their effectiveness with many conditions that have behavioral health or behavioral aspects to change. Any chronic condition requires behavior change if you're unsuccessful.
Great point.
Yes, thank you. So do we have any questions in the queue before I move on?
There are no questions on the queue.
Okay, thank you. Great questions, Karen. Thank you. All right. So we will move on now. I'd like to introduce our final speakers, Michelle Hoover and Archie Hamilton. Michelle is a Quality Improvement Advisor with Adam Alliance. She graduated from the University of Mississippi Medical Center with a degree in Health Informatics and Information Management. She has worked with HealthPort as a Release of Information Specialist and HIPAA Compliance Specialist. She also serves as a member of the University of Mississippi Medical Center Advisory Board for the HIIM program. Archie is a Behavioral Health Manager with Adam Alliance. He has a master's degree in counseling psychology and more than 12 years of behavioral health experience in hospital and managed care settings. He's a certified motivational interviewing trainer and has specialized experience in case management, advancing integrated care, and substance abuse services. We'll turn the call over to you all.
Great. Thank you, Lindsay. And will you pass the ball to me so I can advance slides?
Yes. Just got to scroll down to you. All right. There we go. Oops.
Okay.
Sorry.
Thanks, Paul and Eric as well for their presentation. As Lindsay mentioned, my name is Archie Hamilton. I'm the Behavioral Health Manager with the Adam Alliance Quinn QIO. We are one of the Quins that was awarded the Behavioral Health Task Order that focuses in large part in advancing the integration of behavioral health in the primary care setting. The two primary areas that we're initially starting with are screening interventions for depression and alcohol misuse. In addition to that, beyond implementing screeners in primary care for behavioral health, we're also very interested in advancing concepts of integrated care, very much in line with what Eric and Paul presented earlier. So Michelle and I would really like to just share one example of some of the work that we've had the good fortune of being a part of in Mississippi. Our region consists of Alabama, Mississippi, Tennessee, Kentucky, and Indiana. So without further ado, Michelle, as you began work with St. Dominic in the Jackson, Mississippi area, how did that collaboration start?
Thanks, Archie. Well, we began our collaboration with St. Dominic's in August of 2015 when Adam Elias began promoting our behavioral health project. Our team here in Mississippi began by identifying the major healthcare organizations in our community and approaching their leadership. And during this recruitment period, we reached out to St. Dominic's. And they are a large healthcare organization here in the area, and they operate a large inpatient facility, and they provide care throughout the area in several primary care clinics as well as various specialty groups. Working with large organizations such as St. Dominic's is always a work in progress. And after an avalanche of calls and emails, we still haven't received a response. And then one day, my team partner decided to drop into one of the primary care clinics here in the area, asked to speak with the clinic manager, and as luck would have it, the director of clinical operations was scheduled for a meeting there that day, and she had the opportunity to meet Gabe Hodges and make those initial introductions. And shortly after that meeting, they contacted us and let us know that they were ready to work on our project with us.
Great. Thanks, Michelle. So when you approach an organization like St. Dominic's to collaborate in this behavioral health work, how did you present or frame the message with the organization in those meetings?
Sure. We usually take a multi-level approach with our different organizations, and St. Dominic's was no different. We introduce the clinical benefits of integrating our project into their primary care settings, and we also point out the financial benefits of integrating behavioral health into their practices. Just to explain a little more in depth, our project does promote the use of behavioral health and alcohol misuse screenings in primary care settings, and Medicare allows providers to assign billing codes for the administration of these screeners, and providers are reimbursed for their time. And this is the key to the financial component of our project. If providers screen Medicare beneficiaries during a routine exam, or let's say even a Medicare annual wellness visit, they are evaluating patients for serious behavioral health risk, and they're compensated for that time, and we have some early intervention for our Medicare beneficiaries.
Great. So you really kind of presented, it sounds like, a clinical and business case approach. With St. Dominic's in particular, what parts of that message really resonated with them or drew the most interest?
Of course, with any organization, the idea of expanding another source of revenue is always appealing, but St. Dominic has always placed a strong emphasis on behavioral health care as well. I know many communities throughout the nation have been faced with cutbacks, and some of those cuts, or many of those cuts, have been aimed at behavioral health resources. We're fortunate in this area that St. Dominic's does provide our Medicare beneficiaries with acute inpatient psychiatric services, outpatient services, and they have specialized care for those suffering from multiple behavioral health needs, such as dementia with an added psychiatric problem, or even senior citizens that are suffering from problems with coping with their day-to-day life, and they have extra assistance from these outreach centers.
Great. So we know in the primary care setting, some of the common barriers are, competing priorities, tight time management. What were some of the barriers that you encountered in St. Dominic's clinic at the beginning of this project?
Absolutely. St. Dominic's began the process of educating their providers internally about the importance of behavioral health screenings in primary care. And they also did help providers understand the financial benefits of administering these screeners in their practice. They created their own internal goals, and they even created their own procedures to encourage participation. One of the barriers we commonly encounter concerns the coding and reimbursement of preventive screenings. St. Dominic was willing to take a trial and error approach to the billing of these screeners. Our team met with several key administration leaders, including Mr. Hodges, the Director of Clinical Operations, and the Manager of Billing, in order to address this issue. And during this informal meeting, we discussed any questions they had and coached them on the correct coding procedures involved with behavioral health screenings. And I learned a valuable lesson from this experience because as I went back out into our community and spoke with other healthcare organizations and other providers, I gave them the idea that was passed along to me from St. Dominic for this trial and error method. And this gives their medical coders a little time to get used to coding these new screeners because they are relatively new.
Great. So, and I believe that's one of the common challenges that practices encounter with adding new services is the billing and coding. So, once those initial barriers were addressed and some assistance was provided, how did St. Dominic's respond? What did you see in terms of activity following that intervention?
Well, I have to say that St. Dominic's is just a prime example. They are our Gold Star winner for our project. They listened to our case for expanding these behavioral health screenings, and they took advantage of our collaboration and the help that we offer them, and they invested in it 100%. And thanks to their efforts, they're operating with very little help from us, and they are fairly self-sustainable at this point.
That's great. So as far as St. Dominic's approach to implementing these screening interventions, how did they go about incorporating those into their clinic's workflow?
They are using the onboarded screening templates embedded into their EHR, which include many of the standard behavioral health and alcohol misuse screenings, including the PHQ-2 and the PHQ-9, as well as the Audit C tool for substance abuse. The screeners are administered by nurses during the triage process and then followed up by the providers in the exam room.
That's great. So they've really worked at identifying those staff in their clinics that are going to begin the process and then how to work the patient flow through the exam process. Excellent. So after all of this played out with St. Dominic's, what kinds of results did they see in terms of number of screeners and impact on their overall business?
Well, they began using the screeners in June 2016, and they began regularly screening their Medicare beneficiaries in their clinics. And as a result, St. Dominic has successfully billed and has been reimbursed for 6,589 preventive screenings over a 5-month period between June and October. And, of course, it averages out to around 1,200 screenings per month, which is a very impressive accomplishment. And as our presentation points out, it also generated over $100,000 of revenue for that 5-month period.
Great. So, Michelle, we've gotten some of those screening interventions implemented. What are the next steps with an organization like St. Dominic?
Sure. As I mentioned earlier, St. Dominic's is self-sustainable now, but the Adam Alliance will continue to collaborate with St. Dominic's on implementing concepts of integrated care into their system of clinics or provide any technical assistance they may need. Recently, I attended a conference related to the Transforming Clinical Practice Initiative and ran into Mr. Hodges, and he is ecstatic about the success and progress of our project.
Great. So it sounds like more to come, Michelle. Thanks and great job and good work with St. Dominic.
Okay, thank you.
Nikki, I will pass the ball back to you.
Thank you, Michelle and Archie, for sharing your story with us and for being here today. So at this time, we'd like to open up the call again to questions and comments for both Michelle and Archie. So Karen, do you have any questions in the chat?
I don't see anything of our attendees in the chat.
Okay. Before we, I'm sorry, go ahead.
Oh, is there anyone trying to call in?
Yeah, let's have Sylvie remind our participants how to ask a question via the phone line.
And yes, again, if you would like to ask a question over the phone, that's star followed by the number 1 on your telephone keypad. And there are no questions over the phone.
Thank you, Sylvie. Go ahead, Karen.
I was wondering, for Archie and Michelle, based on your experience thus far with implementing behavioral health screening into health systems, what would you tell the audience would be key factors to sort of just intuitively assess the readiness of a health system to even consider implementing the screenings before you even presented your case? What would you say has to be in place logistically and just kind of mentally readiness-wise for the health system to be ready to consider the screening implementation?
That's a great question, Karen. I'll give a brief note on that. I think you mentioned assessing readiness. Knowing the facilities or practices that you're collaborating with is really key. You need to know where they are conceptually as it relates to behavioral health care. Do they have any level of integration? Have they adopted, any level of integrated concepts? What kind of technology do they have? Are they on a specific EHR? Are they still on paper or some combination? What's the kind of level of readiness for their staff, whether it's the MPs, the nurses, the physician's assistants, and the physicians themselves. Just getting a sense of where that comfort level is as it pertains to behavioral health. And then I think Michelle and the team in Mississippi did a great job of St. Dominic and really finding some points, some internal motivations that they had as an organization, and then leveraging those. Every practice and facility has a lot going on, minimal time, lots of competing priorities, and it really helps for us in an effort to work with them to align kind of the tenets of our project with where they are, when we meet them, and then kind of starting there. And St. Dominic's is one of those facilities that really was already somewhat ahead in that process, and Michelle was able to kind of identify that and work with that in particular, and they really ran with it.
Great. Seeing no questions still in the chat.
There is a question in the chat, Karen.
Oh, great. Oh, I do see one. Yes. How did the Project ECHO Behavioral Health Collaborative Care Program at the University of Washington work out? I think that's Washington State. And do they have advice on spread?
That looks like that might be a question for Paul. I'm not entirely sure.
How are you for having with them?
So Project ECHO isn't a collaborative care program. Project ECHO is a program that started in New Mexico and has been used at the University of Washington and other places around the country. And again, I'm not an expert on Project ECHO, but some of my colleagues speak on the panels, and there are usually a lot of healthcare providers that provide information to primary care docs in the communities around really complex patients. And my understanding is that in a 1 to 1.5 hour session, maybe 1 or 2 patients is covered, which is very different than the collaborative care model, where we cover 40 to 50 patients in 2 hours on a weekly basis around the same caseload. So it's a very different program.
Okay, thank you. And if you're within the Quinn 2IOs, you might want to stay tuned. We are going to be featuring Project ECHO on a sharing call in January, right after New Year's. And I am familiar too with the University of New Mexico. I think they've integrated a behavioral health collaborative care program in New Mexico prior to Washington's implementation. So they might have more lessons learned in the behavioral health area than Washington does at this point.
This is Paul. I'll just make one comment. So, like a lot of words and again, I may not fully understand what the New Mexico version of this is, but there is sort of a common use of the word collaborative care, and then there's a specific clinical model and a research model. And for 20 years or so, we've been doing randomized control trials in collaborative care that specifically outlines a methodology that includes all the elements that I showed in the core components. What's happened in the last 2 or 3 years is that collaborative care is being used to describe any kind of team-based care, regardless of the format. And so unless, and again, there's nothing wrong with that. It's just the way it is. But it does lead to some confusion because if you do look at the evidence base of collaborative care, where there's, now 80 clinical trials and meta-analyses of these trials, they really are focusing on a specific clinical model. And the key features of those are, having frontline clinicians that are working on, they're usually social workers or nurses, where there's a weekly systematic case review of a whole caseload, and where there's tight-knit coordination and communication with the patient's PCP. So that's what the traditional concept in the clinical model of collaborative care is. Unfortunately, collaborative care now means almost everything. It's sort of what happened to the word patient engagement and to the word patient-centered and so on. So I think we just have to be careful about what we're calling collaborative care. Having said that, maybe Project ECHO is doing exactly what I just described, but I really don't know.
Thank you, Paul. I think Karen actually lost phone connection. This is Lindsay at the NCC. Sylvie, do we have any other questions in the queue or any questions in the queue?
We don't have any questions over the line at this time.
And not to put any of our presenters on the spot, but if you have any questions of each other based on presentations, you can also feel free to ask those now.
This is Archie. I have a question for Eric and Paul. So telepsychiatry, how do you guys see that playing a role in integrated care and collaborative care model in the future of integration?
Well, Paul here. I'm happy to start. So first of all, if we think about telemedicine in general, telepsychiatry is clearly one of the disciplines or one of the ways clinically that telehealth aligns with. There are fewer limitations to telepsychiatry because of the nature of the interaction. It's an interview and questioning and looking at emotional gestures and so on. So a lot can be derived from that methodology. I think that there's a great shortage, a tremendous shortage of psychiatrists in this country, or individuals who are otherwise, prescribing meds or doing evaluations that aren't necessarily psychiatrists. The main point is that there's just a dearth of resources for mental health. And so I think that telepsychiatry definitely has a place, and just like telemedicine has a place, especially for hard-to-reach populations. From the standpoint of chronic disease care, and I know this because we're talking to a number of telemedicine companies who provide telemedicine for acute care, and then there's telepsychiatry that does assessments for psychiatry. But I think there's also a tremendous role of telehealth for chronic disease care. If you think about it, so much of chronic disease care is what happens between healthcare visits, and it's around behavior change, and it's around skill building, about helping patients understand more about their numbers, their trends, and with telemedicine, and that can all be shared. So just expanding on your question, you can imagine that a case manager could actually show a patient, their change in their PHQ over time. The case manager, it's a far more personal experience. And the other thing about thinking about depressed individuals or individuals with multiple chronic psychiatric or behavioral conditions is that, they have low energy or lower energy, poor concentration, they feel overwhelmed. And so bringing care to them as opposed to expecting them to coordinate their lives in a way for frequent visits, is a much better prospect for engagement. I'll stop there and see if Eric has anything to add.
I agree with Dr. C, and would add that it can be used for these review of patients, like on the registries and the collaborative care model, and often is, and perhaps the psychiatrist has remote access to the record, but the team is able to meet together through telepsychiatry. So it makes me think about the scope of service. Are we talking about, one patient at a time, a traditional sort of arrangement that happens to be using technology, but now we're seeing it used for this collaborative care model. We're seeing it used in emergency rooms for consults. Which really varies and stretches the scope of work for psychiatry. The next piece is getting, all of psychiatry or a larger portion of psychiatry more comfortable and familiar with consultation roles versus a provider role. Some naturally kind of gravitate in that direction and do both nicely, and others might be more in a traditional provider role where they require much more information, they want to see the patient, and we need a good portion of psychiatry to function in a consultative role so that we can stretch that expertise to meet our needs. We're never going to have enough psychiatrists graduating from residency programs to get those first appointments within any reasonable time frame. So we need consulting psychiatry.
I just wanted to add one more thing, and Archie, that's a great question. At the last presentation, I didn't have the slide in this presentation, but I did show a slide of a randomized controlled trial or clinical trial comparing practice-based collaborative care with centralized collaborative care. And this was in FQHCs and looking at depression only. And the centralized utilized telehealth, both for the psychiatrists and for the care managers. So telehealth meaning not just telephony, but also telemedicine. And what they found was that the outcomes were far more robust in the centralized care management, which seems paradoxical, but if you think about the real-world challenges of running a practice-based program of any kind where you have competing demands and where people that might be doing the practice-based collaborative care are doing, 3 or 4 other things, there's tremendous, interruptions and so on. I see they cite this in the article as well. Whereas when it's centralized and you can address a whole geographic area and all those folks are doing, either the care managers or the psychiatrists, either going from one case review to one, to another, and they're also centralizing their efforts, there's much more opportunity for quality improvement and for skill retainment as well. So I do think that, you know, if we're talking about any kind of centralization, it usually leads to telepsychiatry, telemedicine, telehealth.
That's very helpful. Thanks to both of you for your answers. Because in our work, I mean, one of the greatest challenges and barriers are the lack of behavioral health resources in the communities we serve. And in our region, there's a large swath of rural areas, which is in addition, you know, another layer of challenge there. And telepsych and telehealth, for that matter, seems to be a viable option, and we've, you know, seen some folks take advantage of that. And that's, you know, one with St. Dominic's, because they had the internal behavioral health resources. I think that was one of the things that allowed them to just kind of go out of the gate at a full, you know, pace. But that's a unique scenario, and we really struggle to help folks connect to behavioral health in particular.
Thank you all. It looks like there are no further questions in the chat, so I'll check in with Sylvie again.
There are no questions over the phone.
Okay. Well, if we have no further questions, I think we can move on to our call to action. So now that we've heard from all of our speakers, we do have some asks for our audience. And these may look familiar if you've participated in the November 1st National LAN event. The first is to consider if one or more models of integration might fit into your organization's practice site. So what resources and adjustments would be needed for this model. Todd has provided 2 articles and an infographic on his collaborative care model. These are posted on the QIO program website, and Karen has or will share that link in chat. We encourage you to review these resources and share them with your colleagues and partners. You can start applying today's strategies and best practices immediately. And our next call to action is asking you all if you have a story to share. Has your organization experienced successful integration of behavioral and physical care? On the other hand, what are some of your challenges? So please share these with the Point NCC by emailing Nikki Rosales, and Karen will include her email in the chat. These stories really help guide the content for our future learning activities. And as we mentioned earlier, we'd love to hear topic ideas from you all. So for those of the future offerings through this venue, if you have any needs or ideas, please send those through chat. You can email us at QINNCC@areas-d@hcqis.org. We'll put that in the chat. Or you can provide any ideas in the post-event assessment. In the next slide here, we have a save the date. We'd like to invite you to join us for the next formal National Learning and Action Network event, which will be on Tuesday, February 7th, 2017. The topic will be focused on working with communities to promote best practices of healthy living. And then we would like to take a moment to ask you to complete our post-event assessment. The individual feedback you provide helps drive our future calls. We review and consider each and every response and all of your feedback. If you have any questions about those assessments or anything else, please contact Nikki Rosales. Her email address is now on the screen. With that, if there are any last questions, you can submit them through the chat. Upon closing the WebEx session, you'll be invited to share your thoughts and feedback through that post-event assessment. We greatly value this feedback and appreciate you taking a few minutes for completion. And I'd really like to thank all of our speakers today, Eric Christian, Dr. Paul Chomsky, Michelle Hoover, and Archie Hamilton. And of course, thank you to all of our participants for being with us today. Have a great afternoon.
This concludes today's conference call. You may now disconnect.